So if you'd take your seats, we'd like to get going this morning. My name is Greg Hager. I'm the director of the Malone Center for Engineering and Healthcare, and I'd like to welcome all of you to our inaugural symposium on engineering and healthcare here at Johns Hopkins University. We've got a packed day today and a tight schedule, and we've got people watching online who are even looking at our schedule and tuning in for talks, so I'd like to try to keep us going on time. So without further ado, I'd like to spend just a few minutes giving the Dean of Engineering and the Dean of the School of Public Health a chance to say a few words. So I'd first like to introduce Ed Schlesinger, the Benjamin T. Rome Dean of the Whiting School of Engineering, to step up and say a few words.
Thank you, Greg. It is my pleasure to welcome you all here today. I think this is a very important symposium building on interesting directions that we've been developing at the intersection of engineering and healthcare. And meeting here at the Welch Library, I think, is itself a symbol of the growing integration of engineering and healthcare and medicine in terms of solving some of the most important problems of the day. We have a number of leaders of the School of Medicine, School of Public Health, nursing joining us today, as well as from the School of Engineering, and some of them will be speaking throughout the course of the day. But this symposium, as I said, truly is a manifestation of, I think, who we are at Hopkins in integrating disciplines. Today's focus is on the present and on the future of healthcare, but I think it is worth noting that much of what we take for granted in medicine today around the world, in patient care, in education, diagnosis, and treatment of disease, was invented here at Hopkins, originated here at Johns Hopkins. In fact, some things that are so obvious, the practice of bedside teaching, of physicians discussing cases in front of assembled medical students for the benefit of patient and students. What we know as grand rounds, all originated here, and they're so integrated into what is modern medicine that I think sometimes people don't even realize that somebody actually had to invent them and create them. And I think we are now at a new threshold, a threshold of a dramatic change in the way medicine and healthcare, medicine is practiced, healthcare is delivered, and how engineering plays a role in that. And I think it is our partnerships between School of Medicine, Public Health, Nursing, the Applied Physics Lab, the School of Engineering, that's going to fuel a new revolution that will ultimately be looked back at by people who won't realize that there was a time that all of what that then becomes standard operating procedure actually was invented. And so this is where we are today, to invent the future. There's already so many examples of the way we're integrated together. Our departments of biomedical engineering in the School of Medicine and Engineering, our Department of Environmental Health and Engineering in the School of Public Health and Engineering, our Institute for Computational Medicine, our Institute for Nanobiotechnology, the number of joint Bloomberg distinguished professors that we share. So it is truly the case, I think, that these sorts of partnerships are accelerating innovation across the university. They spur translation. We have the opportunity to make tremendous impact. And so I think, again, this integration, this collaboration through integration, this bringing together of a diversity of ideas and points of view is our opportunity to truly lead in this new space. And with that, I would like to, again, welcome you all here today, and specifically welcome Dean Klag, Dean of the Bloomberg School of Public Health, to the podium. Thank you.
Thanks, Ed. Well, let me add my welcome as well. This is really exciting. We all know that great things happen when people cross disciplines, and when you bring the methods and sensitivity of one discipline to the problems of another. At our school, we've had a long association with engineering. Abel Wallman, in the 1930s, when he came to head the Department of Geography and Environmental Engineering insisted on an appointment here in the School of Public Health. And throughout his long career, he was a great friend. He helped us envision programs in our Department of Environmental Health Sciences. And then his son, Reg, when he was chair, he was equally supportive. And for example, Kellogg Schwab, who heads our Water Institute, was recruited by Reg Woolman to come here. And then I look out and I see all the collaborations we have now with engineering, as you mentioned, with computer science or our Center for Public Health IT. And then recently, we have created a new department, the School of Engineering and the School of Public Health. Our Department of Environmental Health Sciences and the Department of Geography and Environmental Engineering have created this new department of Environmental Health Engineering, which is going to help us institutionalize those cross-disciplinary collaborations. So we're really excited. As I was thinking about this symposium this morning, it brought me back to when I used to see patients years ago, and I had this very complicated patient. She had multiple problems, and her husband was an engineer who worked for GE. And he would come to every clinical encounter, we would do the clinical stuff, and then he would look at me and say, "You need engineers. You really need help." And so I think this is this is coming to fruition of that that recommendation many years ago in clinical care. So I look forward with you to an exciting day today, and also to years of working together in collaboration to improve healthcare and public health. So have a great day.
Thanks very much for your remarks. What I'd like to do is to spend maybe the next 20 minutes or so now talking a little bit about the opportunity space that we plan to be addressing over the next few years. So this is a symposium that is really coming out of, I think, as you just heard from Dean Schlesinger and Dean Klag, the idea that we really need to create vehicles and methods for engineering and healthcare to work together to the benefit of both. And so I'd like to spend 20 minutes just giving you a perception of what that space might look like. And as we go through the day, I think you're going to see different perspectives on this problem space. So I always like to start with just saying, what are we really trying to solve here? I think, as I go into the School of Medicine or the School of Public Health, I can talk to any clinician, I can talk to nurses, I can talk to patients, and they certainly have a perspective on their problem space. But if we zoom back a little bit, this is really the problem space that we're looking at. So for those of you who don't track the statistics, healthcare costs just passed about $3 trillion this year. It's about 18% of the GDP of the United States. And if you start to dig into, well, what are some of the factors that influence those costs, you start to see that there's really, on the one hand, a wealth of opportunity in healthcare. We're getting better and better at building diagnostic tests. We're getting better and better at coming up with new ways to treat patients. But that means that the system itself is growing in complexity. So if you talk to a doctor, they will tell you that their life today is far more complex than it was 20 years ago. And it's not only the complexity of diagnosis and treatment, understanding what's going on with the patient or what treatment they should prescribe, but it's the number of patients and the number of activities that they have to participate in. So this is again from a report from the Institute of Medicine, now the National Academy of Medicine, where they report ICU clinicians with 180 activities per day, or one doctor who in their practice has to interact with 200 other doctors in the care of their patients. So we're dealing in a world where complexity is growing rapidly from nearly every perspective. And the result of this really is a set of inefficiencies in the healthcare system that we really as a nation need to address. So one-fifth to one-third of patients preventably harmed during stay. Later today, Peter Pronovost will be giving a keynote talk. He's director of the Armstrong Institute in Patient Safety. And he can talk at length about why these errors occur, but fundamentally we need to understand and address this issue. recommended care, so only about half of recommended care is actually delivered. So the effectiveness of a treatment is not just how well does this treatment work in the lab, it's how well does it work when you actually field it in the real world. How do we actually improve that aspect of effectiveness, not what's happening in the lab, but what's happening with the patient on the street. And healthcare disparities. So one of the founding ideas behind the Malone Center was the question of why is it that the same patient could, in principle, go into two different healthcare systems or two different hospitals or two different clinicians' offices, essentially give the same history, the same sort of symptoms, but they might get two different diagnoses and two different treatments. Why can't we make that uniform and bring the lowest performing hospitals or healthcare systems up to the highest performing healthcare systems? And again, statistics suggest that if care quality of all of the healthcare systems were moved up to be equal to the highest healthcare system, we could save something like 75,000 deaths nationally. So this is our opportunity space. This is a place where we can save money, we can make people's lives better, we can really enhance the effectiveness and competitiveness of the nation. So I'm not the first person to observe this. I'm sure many of you have been confronted with this in many forums. And there's been a series of reports coming out of the national academies on this point exactly. And the key thing here to realize, as I said earlier, is where we're working is not necessarily just in producing better treatments or better diagnoses. It's actually delivering the care that's potentially out there. And so really what we're here today to talk about, and where I see the opportunity space that we'd like to explore, is how do we find these underexploited opportunities to take the treatments we have, the diagnostic tools we have, the data we have, and the potential to put those together to produce better and higher value healthcare. And I do think this is really the challenge for our generation. So how do we do this? Again, this is not a new idea. We need to somehow, though, understand how to realize this idea. And of course, we live in an era right now where we're seeing disruptive revolutions everywhere. Mobile information disrupting transportation, GPS and data analytics creating precision agriculture, robots working with people in factories to enhance productivity through collaborative systems, and artificial intelligence now learning to drive cars and potentially revolutionizing the transportation industry. So nowhere on here do we see healthcare. So how do we now start to move these ideas into the healthcare space? So I think the time is actually right to do so, and I think for a number of reasons. The first is the economics. I've already told you the economics of the situation. You know, the amount that we spend as a country in the United States on healthcare vastly exceeds any other developed country in the world. And as I'm sure many of you sitting here in the audience know, there's a tremendous drive to reduce costs and promote efficiency through a variety of mechanisms that are now being introduced through insurance companies and through some of the national healthcare initiatives. The flip side, one of the key factors that really has changed many of the industries I mentioned before is the availability of data. And it's interesting to look through the introduction of electronic health records as well as the growing use of electronic imaging modalities, that the amount of data available has grown by some estimates by a factor of between 5 and 10 over the last 5 years. So we are really moving into a world where suddenly it is potentially possible to exploit not just new sources of data, but new quantities of data that didn't exist even 5 or 10 years ago. Technology, again, I've already mentioned that, but technology continually progresses, and even though that progression is often gradual, you hit certain points where suddenly that technology becomes revolutionary and transformative in an area. So, you know, the fact that, I don't know how many of you in the audience now are wearing a Fitbit, that's an example of a technology that simply got to the point that it was cheap enough and effective enough that you could now suddenly put it out into a population that you couldn't have before. And there are many examples of these technologies that we could bring to bear to improve healthcare. And the last thing I'd like to talk about is culture. And I think this is as important as anything else. As both Dean Klag and Dean Schlesinger said, this is a collaborative endeavor. And to be a collaborative endeavor, both sides have to be motivated and interested in working on these problems. And I think we really have gotten to the point that people accept these sorts of technology innovations and how they can actually transform their lives in interesting ways. I think patients understand how technology can transform their lives. Clinicians can understand how they could use technology more and more in their practice. Hospital administrators understand that technology could actually let them start to understand and improve their operations. So there's really a collection of factors that I think are converging now to make this a space that in the next 10 years is going to be tremendously exciting to work in. So if we're going to work in this space, I think the next question is, well, what are we trying to achieve? How do we get to something that is better than we had before? And I want to say measurably better. So there's this quote from Lord Kelvin, you can't improve what you can't measure. And that's certainly true. It's very hard to introduce changes without some way to understand whether or not that change has had a positive impact. I think there's a corollary to that, which is speaking from the engineering side. You can't engineer what you can't describe and model. So it's not just about having measurements and data. It's about also being able to understand how that data informs the processes that you're trying to work with. So this is kind of the cartoon that I'm going to use for the rest of my remarks here. Again, it's a very simple cartoon where you can think of a care pathway consisting of a patient coming in, receiving some diagnosis based on some interaction with a provider, getting some treatment prescribed, and this could be anything from simply getting medication to going into surgery, but eventually then recovering from whatever illness they presented with, and that produces an outcome. And the value of the outcome is quite simply how good was the outcome and how much did it cost us to get there. So we can improve value in healthcare in two ways. We can improve outcomes or we can reduce costs. And this really, from an engineering point of view, is a very familiar sort of notion, because what we've just said is we've got a process, and that process should be engineered to achieve a certain optimal objective. Now, unfortunately, this is a cartoon. This is actually the reality. So this is a paper by Raoul Bossol out of Georgia Tech and his colleagues, where they took the electronic health record and they simply extracted from it billing codes and used those as a surrogate for patient flows through their healthcare system. And as you can see, it's a little hard to see my diagram in that plot. But buried in there is the empirical actual fact of this is how the healthcare system operates. This is really on the ground what clinicians are doing every day. And so what we really need to do is to marry those two pictures. We need, at the one hand, an abstraction that we understand and that we can discuss and that we can work with, that we can engineer and optimize. And on the other hand, that abstraction has to somehow be grounded in the empirical reality of the healthcare system. So here are a few areas that we're going to talk about today in terms of trying to now move toward that notion. So the first thing I would point out is both of those pictures are pictures of systems. They're ultimately, on the one hand, a care pathway that would be embedded in a larger system of other care pathways, and on the other hand, the empirical care pathways that patients experience. So how do we bring those together? We need to build parsimonious and understandable models of care pathways. And models, when I say understandable, I mean this in the sense that this is the point where engineering meets medicine. So when you talk to a doctor, they understand what a care pathway is. When you talk to an engineer, they should understand what a care pathway is. And now you can start to actually talk about defining problems in a space of shared concepts that they can work with together. Now, again, we're going to build abstractions. These abstractions have to be reflective of data. So how do you now match data to your abstraction, and then how do you use that to now build tools and methods that move reality to match what we actually can prove, theoretically, to be possible. And this is another key point that I think, as I mentioned earlier, when I go and I talk to any particular clinician, they certainly have their problem that they would like to work on. But what's important from an engineering perspective is not to come up with a point solution, not to solve a particular problem, but to come up with the abstractions so that eventually other people can solve those problems as well. You don't have to chain a computer programmer to every doctor in the hospital to go solve their problems on a day-by-day basis. So really, it's building the abstractions that allow us to think now about an engineering science in healthcare at the systems level. Now, ultimately, we're going to have to field tools and techniques and methods that improve healthcare. So one of the key aspects, of course, is information. I just spent a weekend on a retreat with many of the chairs in School of Medicine, and we spent the entire weekend talking about data and how data could, in fact, revolutionize healthcare. And I have to say, it was really a great experience to hear all the perspectives and also to realize really the commitment and the interest in doing so. And this really is one of the key areas we're going to need to work in over the next few years, is making data not just available, but ultimately actionable. And actionable in the sense of improving decisions, and improving healthcare decisions means you're going to improve outcomes. Improving predictions, knowing where a patient trajectory is likely to go, which means, for example, that maybe you can do a better job of scheduling and decrease costs, both of which obviously improve value. And I think most importantly, exploit health data to manage wellness. So it's even better if somebody doesn't ever show up in the hospital to begin with, because now everybody has saved. And so I think these are areas that, again, over the next 10 years, we're seeing the beginnings of it now, and we're going to see an incredible revolution over the next few years. I think physical is also important. No matter what we do, ultimately, many aspects of healthcare deal with manipulation of the patient, manipulation of the physical world. And later you'll hear from Simon DeMaio from Intuitive Surgical about some of the work that they've done both in developing their innovative product, but also in interacting with academia. But the interesting thing to me about devices is they are what touch the patients. They are the Lord Kelvin's measurement of the physical world. And these devices not only enhance care, but they themselves become new forms of data. So for example, that surgical robot in the OR is an opportunity to make a complete record of a surgery and to analyze that record for example, understanding typical flows in surgery. Not only does it provide data, but it also data to understand, but it also provides data to document outcomes. So again, if you want to do value improvement, you have to understand what the outcome was. And in some cases, that's what that device will be able to do, is tell you something about the outcome as well as the process. Of course, it also provides new ways to manage the physical world, support devices. And I know in our panel this afternoon, at least a couple of the speakers are going to talk about innovative new robots to enhance surgery. And maybe most importantly, ultimately we're talking in healthcare about a system of people and machines. And so this is really an opportunity, just like in that manufacturing example, to say, how do we bring some level of physical support and automation into healthcare to enhance the efficiency, but also really make caregivers themselves more capable and more able to focus on what they should be doing and leave the rote labor to the machine. So this notion of synergy, I think, is also going to be something that I hope we talk about more extensively in this symposium. So lastly, I just want to spend a few minutes on an area we call user-centered design. It's actually the last panel today. So the whole notion of user-centered design is that really you start with a problem. And I think this is also a key aspect of building a culture of engineering in healthcare going forward. Right now, the Homewood campus here at Johns Hopkins and East Baltimore are 3 or 4 miles apart. So it's obviously easy to sit in my office and talk with a clinician on the phone and hear about what they're doing. But it's an entirely different perspective when you actually go spend time in the hospital and you stand in surgery and you round with a clinician and you see what it's like to take care of stroke patients. And that's really where engineering has to move. We really need to be embedded in the healthcare environment, standing next to the clinician, understanding their problems. And so start with their problem and then try to understand how to solve their problem, which means you're building systems not in the abstract, you're building systems in context. You know, if I'm working in the ICU and I have a patient that's coding, I'm not going to sit there and read a long screen of information about what I might do with that patient. I need to know the most important bits of information right now. If I'm a nurse taking care of 10 patients, I need to know where they are in their treatment, what treatment they've had, what treatment they haven't had, what needs to be done. And I need to know that basically at the patient's bedside when I show up. So understand what people need and what they need to do. And then through this, create this integrated engineering culture that is, I think, the only way to move forward in engineering and healthcare. So lastly, we have to define what it would mean to be successful. So if we were to do this, and 15 years from now, we come back here, perhaps in a much larger room with many more people who've all gotten onto this bandwagon, we might say, well, how would we say that we were successful? What would that be? So here's a kind of a simple way to think about the entire process of going from an idea to a deployed system. So you spend a certain amount of time in the idea stage, where you're talking with people, you're defining what you're trying to do, you're getting the resources together, and you iterate for a few times until you actually think you've got something that actually will solve this problem. And now you have to move to realization. So I've got this, you know, my grad student and I, we've sat down, we've got our solution, we're ready to go. And now we say, okay, let's try to field this. Well, now we've got to go from kind of this lab model, if you will, to something that I can actually deploy. I can actually look at how that deployment works. I probably will have to iterate and improve it a few times. And then eventually, if I get it to work here at Hopkins, the next question is, well, how do I get it to work everywhere else in the world? And of course, that's not just taking my piece of code that works at Hopkins and moving it over to the Mayo Clinic. I've got to abstract that in a way that now I can actually pick it up and move it and plug it into an entirely new environment and potentially tune and change it for that environment. So I have to really invest also thinking in how can I scale this out to have larger impact. So if you start to think of the survival probability of any idea as it makes its way through the system, you know, maybe you've got a great idea and you do the experimentation for a while and you're able to get kind of a toy data set, or maybe you're not. Maybe it turns out you have to go through an IRB process and somehow you decide, you know, it's taking too much time and you move on to something else. And so you kind of lose a few ideas there. And then you say, well, I'm going to now really build this against the EHR, which means I've got to structure data in some sort of way. So I try to build out a sandbox system. And now there's a whole new level of effort I have to put in. And so a bunch of things drop away. And then I say, well, the sandbox system, that was offline. That was just kind of proving a retrospective data at work. Now I want to really run like I was running in the healthcare environment. Well, now there's a whole new set of people you get to talk to and a whole new set of challenges you have to face. And a few more systems will drop away. And then you actually deploy it. Now you've got to work with somebody to actually assess it, improve it, adapt it, finding that person, getting it out there, finding the resources, a few more drop away. And then finally, things that actually scale out, you know, you actually do the abstraction and say, let's make it work in the real world. A few more drop away. And so you can see the number of ideas that survive the gauntlet of actually going from idea to deployed system is fantastically small. And it's because in many ways there are so many steps and so many things that we need to go through just to make that happen. So my definition of success in the future would be quite simple. So if we think of this as the reality today, and I actually believe it is the reality today, there are two things I think we want to do. The first is we obviously want to make it a lot easier for ideas to get out to the end. You know, I wouldn't want to say we want to create an app store for medicine, but certainly we want to go down the road of saying how do we open it up much, much more than it is today. So can we double the probability of actually an idea reaching deployment? Can we make that grad student empowered to actually make it to the end of that food chain? And also, we'd like to have the time to do it. The number of years it takes to go from that idea to that system is phenomenal. And it is literally years, it's not months. So can we have the time to completion? So not just double success, but make it happen faster too, so that we can learn and that we can iterate in a more effective manner. So that is my personal definition of success. I think that's why we're here today. The neat thing, I think, about this symposium, about the day, about the panels, is that the people in the room to make these changes happen are here. So I can tell you, I know who's registered. We've got clinicians and clinical faculty from the School of Medicine. We've got engineering faculty from the School of Engineering. We've got researchers from the School of Public Health, and we've got participants from the School of Nursing and also from our Applied Physics Lab. So the pieces of this puzzle, the way to move forward, is sitting in this room today. And so what I would like to challenge all of you to do today is to really think of this as the beginning of creating this change. So as we go through the panels, we're going to have people presenting about work they've done, inspiring us with ideas, also pointing perhaps the direction to the future. But after the talks, we have open discussion, and I really urge all of you to participate, to be an active participant in shaping these ideas. Likewise, we're trying to give a few different perspectives, both from a healthcare point of view by Peter Pronovost and from an industry perspective from Simon DeMaio. And so again, kind of challenge the thinking on both sides. We really need engineering, healthcare, and ultimately commercialization to work together. At the end of the day, we've also got a set of poster presentations. Many of these posters are grad students who are already working in this space, and I invite you to grab a glass of wine and to go talk to them, because they will be the next generation in this area. A few years ago, or actually now several years ago, Russ Taylor and I were involved with an NSF Engineering Research Center in computer integrated surgery. And that started, I guess, what, Russ, 15, 16 years ago now.
I wrote the proposal in '96, so it was 20 years.
20 years ago we started. And the most interesting metric for me of that center is if we now go around the country and we look at where the students that were in that center are located. Many of the universities that have now programs in medical robotics came out of Hopkins. I think many of the key employees at Intuitive Surgical have come out of Hopkins. Really, we created a next generation of engineering students who were acquainted with healthcare. They were interested and passionate about what they could do in healthcare. And they're actually the ones who are going to be out there changing the world 10 or 20 years from now. So definitely spend time with the students who are here, give them your feedback and advice and perspective. And really, it sounds cliche, but help us to start to change the world just as the founding fathers of Johns Hopkins changed the world of medicine in the United States when they created the Johns Hopkins School of Medicine. So thank you very much, and I'm looking forward to interacting with all of you through the day. I'll take a few questions, but maybe the first panel can start to get set up while I do so. Thank you.